Hello. Am I audible, guys? Great. Yeah. So, good afternoon, all the staff members and my dear students. First of all, let me take this opportunity to wish you all a very happy International Day of Radiology, which is also known as Röntgen's Day. So, basically, it all began on one fine evening. It was 8th of November, 1895, and a scientist, or you can call him a physicist, who was German, and he was experimenting in his chamber regarding an experiment with a Crookes tube. Now what he noticed at this Crookes tube is that there was a small glow, or you can say a peculiar glow that took place on a piece of paper that was lying on a carpet. This glow took place only when the electrons, or only when the electricity was passed through the Crookes tube. So as there was no light that was evident to cause that glow, what he concluded is that it was some mysterious rays that were being passed from the Crookes tube and which were reaching the carpet area, which was causing the glow. This actually, my friends, he named it the mysterious rays as X-rays, because everything unknown we write it as X. That's why it was named as X-rays. For this, Röntgen was awarded a Nobel Prize as well. Now, it is rightly said that every successful man has got a woman behind him. Well, this successful man never had a woman, but I can say that he had a woman's left hand behind him. What you can see here is Bertha Röntgen's. So this was the first radiograph that was shot, and it was of his wife's left hand. What you can appreciate here, do not miss the wedding ring that you can appreciate. Good enough, right? So, since the discovery of X-rays and utilization of these X-rays into multiple industries, which we can say that whenever we reach the airport, the first thing that we do is the baggage check-in, right? And that goes through the X-ray scanner. So the use of X-rays has been done in multiple industries, right at the airport to the medical line of use. That means the therapeutic as well as the diagnostic part of it. So we have actually come a long way, right? Now, I, Dr. Abhijeet Sande, reader from the Department of Oral Medicine and Radiology, would now like to take you all forward on a virtual tour in adding a third dimension to conventional radiology, which is called as CBCT, or cone beam computed tomography. Now, in a human brain, in order to understand any concept, requires answers to three potential questions. One is why, the second is what, and the third is how. So the first question that we might be addressing is, why do we require CBCT? We already have X-rays, we already have IOPA, OPG, all the X-rays that are available, but why do we require CBCT then? In order to understand that, we can see here a diagram. Now let us describe this diagram and try to gain some information out of this. Okay? So what you can see here is a house. The roof of the house is triangular in shape. There is a small chimney that is popping out from the roof. The roof of the chimney is again triangular in shape. Is that sufficient? Easy? Clear to understand? Yes? So that much information we have got. Now let us try to see the same scenario in a different perspective or in a different view. So if we see it from the side, what extra we can see is that the house that we were speaking, or the roof that we were speaking, which was triangular, is actually broken from behind. The chimney that we said, which is popping out from the roof, is actually not a chimney, but it is actually a pole which is way apart from the house. And the pole and the house are separated by a bluish water body. Good enough? That serves the purpose with this image, right? Moving ahead, if I tell you that we can have one more view to the same scenario, and that will be the top view. Now from the top, what we can achieve is that the roof that we were saying of the house, which was triangular until now, is actually conical. If you're able to say this, it is a conical. It has what a breach from behind. The pole, the roof of the pole is also conical. It is not triangular, it is conical. The roof, the pole and the house were separated by a water body, but that water body was never rectangular. It is in a zigzag fashion. Good enough? And nor the pole and nor the house are in contact with each other or the water body. So this much amount of information we were able to gain only by changing multiple views. This clinical scenario, if you're going to apply it into our clinics, what we can see here is when we use these X-rays for a two-dimensional image, which is an IOPA, OPG, or any kind of image, what happens when X-rays are going to pass through the source, and when they pass through the three-dimensional object, the resultant image still remains two-dimensional. So the distance between these two objects is never appreciated here on this image. The same thing you can appreciate it in an IOPA. What you can see here is an impacted tooth. You can see here as 7, but you can see here a overlap that is present. Now whether this tooth is buccally placed or lingually placed, we cannot comment anything on it. One more important thing that we cannot comment is on the mandibular canal. We can see here mandibular canal, but the roots or the apices of this tooth are in the canal, or are they lingual to the canal, are they buccal to the canal? Nothing can be commented. This is the limitation of two-dimensional image, which is overcome by getting a scan of a CBCT. Good enough? Easy to understand until now? Yes? Okay. Moving ahead, I guess now we have understood why CBCT is needed. Now coming to what exactly is CBCT. So CBCT basically, it is a radiographic imaging method that allows accurate three-dimensional imaging of hard structures. Good enough? So what you can see here is the image of a CBCT machine. You can see here is the patient who is present in the center. You have the X-ray source that is present on one side, and you have the sensor that is present on other side. That's it. That is a CBCT machine. Right? Then let us understand how does the image acquisition takes place. So when the patient is going to stand in the center, what you can see here is the source of X-ray and the sensor are moving in equal and opposite direction. So this is called as reciprocating motion. You must have come across this reciprocating motion in your OPG lectures as well, right? The same thing which we do it in digital OPG, it is the same thing that is repeated in CBCT machine. Are you able to understand this? So the patient is standing in the center, you have the source of X-ray, you have the sensor that is moving around the patient, and it is in a reciprocating fashion, which means in equal and opposite direction. Good enough? That is how an image acquisition is taking place. But here what is happening is that every time there is a movement, taking place, there are large number of X-rays that are going to be emitting out, which are going to cause an image formation. So multiple images are going to be formed. If you are able to understand this, multiple radiographic images are going to be formed, and in a software when they are going to be given, they are going to be combined together to form a three-dimensional reconstructed image. Understand this. The CBCT image, what you see is a three-dimensional reconstructed image. That means multiple small images were combined together to form a single volume of image. In order to understand this easily, what you can give it as an example of a loaf of bread. All the multiple slices are basically the various radiographic projections that were taken. When they are combined together, they form a single loaf of bread. But the peculiarity of this scan is that you can remove any slice at any point of time. You can take a look at that slide from all the directions, and you can place it back into the loaf of bread. So that is the highlight of a CBCT scan. Moving forward, we already had something called as medical CT, which is called as computed tomography, right? You must have seen a CT scan machine, a larger gantry, the patient is sleeping, the patient goes inside the gantry. You must have already seen that, right? So we already had a CT machine. Why do we require a CBCT machine then, which is specifically to the oral structures? So this is the reason. If you go ahead with comparison of the exposure to the patient that is taking place, what you can understand is a panoramic, a regular conventional panoramic OPG machine is going to give an exposure to 10 to 15 microsieverts. While that of a digital panoramic radiograph, it is going to be of 4.7 to 8.5 microsievert. If you come to full mouth IOPA series, it is only 150 microsieverts, but a medical CT is going to give an exposure of 1200 to 3300 microsieverts, while a CBCT scan is only going to give an exposure of 25 to 50 microsieverts. That's it. Good enough. So if you're going to compare medical CT with CBCT, definitely this is going to be highly useful because there is less amount of dose that is taking place. In comparison with medical CT again, which has got a high radiation dose, the cost of medical CT is much high than compared to a CBCT scan. The availability of medical CT is less, and definitely the scanning time that is required is much high as compared to a CBCT scan. So in a CBCT scan, it is just like you are taking a digital OPG where a single rotation is going to capture the entire volume and the scan will be in front of you. Good enough? The basic difference between a medical CT and a CBCT is that the medical CT that we talk about has got a fan-shaped beam. So the X-rays that are going to move out from the X-ray source are going to be in a shape of a fan. So only that much amount of exposure at area is going to be imaged. Are you able to understand that? But in case of CBCT, what is happening? It is called as cone beam. So the beam is in the shape of cone. So once an entire cone is going to be exposed, the entire volume of the patient is going to be captured in a single 360-degree rotation. That is the basic difference why we call it a cone beam computed tomography. Now before moving ahead in understanding the software, it is highly important to understand the cardinal planes. What we have seen in the first three slides, the top view, the side view and the front view, the same things we are going to be talking in this cardinal planes. So what are these cardinal planes? Basically, you have already studied this in anatomy. The cardinal planes, the first one which we are going to talk about is the mid-sagittal plane. What is a mid-sagittal plane? So it is a plane that is going to pass through the midway. So it is going to divide the body into right and left. That is called as a mid-sagittal plane. Then you come across something called as a coronal plane. Coronal planes means when we are going to divide the body like this into front and back, it is going to be called as coronal plane. While an axial or a transverse plane, it is when you are going to divide the body like this into top and bottom, it is going to be called as axial plane. So we have seen three different planes because when we are going to go ahead with the lecture, we are going to talk only about these three planes. So please understand this, the mid-sagittal plane, the coronal plane and the axial plane. Well, now when we are going to apply this on the skull, this is the resultant thing that you are going to get. A mid-sagittal plane, this is the dry skull if you are going to slice it in the mid area, and this is the resultant image that you are going to obtain. Are you able to understand this? Simple enough, right? So this is the mid-sagittal plane. These are the coronal planes. So in a coronal plane, the radiograph is going to appear like this. While in an axial plane or transverse plane, it is going to appear like this. So from what level my plane is passing, depending upon that, the vital structures are going to be seen. Now you are not used to see these vital structures like this because you have not seen multiple scans. But understand this, if you understand the planes, it is very easy to write an interpretation related to that. Good enough? So three different planes. Can you tell me? The mid-sagittal plane? Very good. Now moving ahead. So how does a software look? So whenever the scan is completed, the patient goes home, but the scan is going to be given to a radiologist who is going to do the reporting part of it. Now a radiologist, when he is going to see the scan, this is the image that you are going to get. Now there are multiple softwares available. I have used a Kodak software which is easy to understand. What you can see here is the first picture or the first window is a 3D reconstructed image. Do not go to the pathology that is present here. Just understand how we are reading or how we are trying to read the scan that is given. So the first window that you can see here is a 3D reconstructed image which we can already see, right? Now what you can see here, there are 3 wire frames that are present. One is a green color wire frame. Are you able to appreciate that? A green color wire frame, a purple color wire frame, and a yellow wire frame. So all these 3 wire planes that we are talking about are the 3 cardinal planes which we have already spoken. The green wire frame will actually correspond to the green window which is here. Are you able to appreciate that window? So this window has got in the corner a green color. This window in the corner has got a yellow color. This window in the corner has got a purple color. Good enough? So depending upon where the wire frame is passing, the structures are going to be seen in that subsequent windows. Easy to understand? So what you can see here is a wire frame which is passing through 1, 1. So what you can see here, where you will see this frame, you're going to see it in this window. So this is the mid-sagittal section. Are you able to understand this? Yes, very easy to understand. The same thing we are going to talk about the purple color. The purple color wire frame is actually the coronal section that we are going to talk about, and you can see it in this window. While the axial section or the transverse plane, which is yellowish in color, the yellow color window is this, and these are the various roots and the multiple canals that you can see here. Are you able to understand this? So reading of a CBCT scan becomes easy if you understand all the windows and the planes. Good enough? Understanding the slicing of a scan again gets more difficult, like finding a correct Google Doodle. Can anybody tell me which is the correct Google Doodle here? Everything appears to be same, right? Everything appears to be right. Which is the correct one? Nobody knows. So it is as confusing as creating a slices in the scan. Understanding the slicing of the scan, one of the important thing that you need to know here is, now this was a scan, or this was a patient who was referred to me for a CBCT scan. What you can see here is an impacted tooth that was present. I'm not here to explain the pathology, but I'm just going to tell you how to do the slicing in a scan. So a predefined area, if you're able to see, appreciate here, something in blue that has been written. These are actually the lines that are passing like this. So in a predefined area, I have done the slicing, the mid-sagittal slicing of this scan. When I am going to appreciate this down below, it is going to appear like this. So every window has got some numbering that has been written here. 1, 2, 3, 4, 5, 6. Are you able to appreciate that? Yes, so every window has got a numbering that has been given which coincides with the line that passes through the scan. Are you able to understand this? So what I have done is that I have taken a predefined area and I have done multiple mid-sagittal slicings of that area. The slicing are going to appear like this. Each window is going to have a number, and that number is going to actually show me where the slice is exactly passing. So that gives me an insight where the exact pathology is and what is the exact dimensions of that pathology. Are you able to understand this? Yes? Good enough? This is again a case of a mandibular edentulous area which had come for a planning of implant. Now for an implant planning, again what happens is that you can see this is a survey radiograph or an OPG like radiograph, easy to remember, right? A mandibular canal nerve has been marked here already, okay? And whatever blue you are able to see are actually the mid-sagittal slices that I have done. So in this edentulous area, I have taken almost 100 of slices with a gap of 1 mm. All those slices are going to be represented here down. So when I'm going to see here the number of the window, I'm going to coincide that with where I am exactly in this slice. Yes? Now with that what I can do is that whenever I reach in the edentulous region, and now we are going to take a look at where all conditions we can use this CBCT. Well, basically the CBCT is going to be utilized in all the branches of dentistry. Let it be OMDR or let it be ortho. It is going to be utilized in all the branches. We'll see a case scenario one by one to understand that where we can utilize this CBCT. Now in case of oral medicine, where cyst and tumors are going to be present, we are going to locate the cyst or the tumors the exact location, the extent, the margins, all those things can be easily appreciated on this. Now this image is quite familiar for you guys, right? We have already explained this image. So this is the, which section? Axial section. This is the coronal section. Well, this is the mid-sagittal section, right? It becomes easy to understand now. So now if I'm going to describe a cyst or a tumor that is present, what you can appreciate here in a three-dimensional area is a big halo that is present. Good enough? Is a big halo that is present. My wire frame, when it is going to pass through it, this is the resultant image that I get. Right? Now what you can appreciate here is a big radiolucent or hypodense area that is going to be present in the anterior region and which is causing blunting of the apex of that tooth as well. Blunting of the apex of the tooth is a classical sign which can be said as external resorption. So we can say that this tooth has got some external resorption because of the cyst that is present. Good enough? Coming to the cortical plate, what you can see here is the ballooning of the buccal cortical plate or the labial cortical plate, which can be appreciated, while the lingual cortical plate is not present, it is not seen. This might be a case of an infected cyst which has completely resorbed the lingual cortical plate and it has got expansion of the buccal cortical plate. So all this information can be easily achieved by a mid-sagittal section. Coming to the same area, axial section, what you can see, the extent of the lesion. So anteriorly till where it is extending, posteriorly till where it is extending. Anteriorly what you can see here, the resorption has taken place right till the nasopalatine canal. Right? If you are able to appreciate this nasopalatine canal here, yes. So the resorption of the bone has taken place until the nasopalatine canal, and distally, that is posteriorly, it is extending till the mesial surface of root of 5. Are you able to appreciate this? So this is how we are going to see a cyst in multiple dimensions. Now with the same cyst, when you are going to see it in coronal section, what extra information we can get is there is damage to the floor of the nasal fossa. So if you are able to appreciate this, the nose, right, the nasal turbinates. So the floor of the nasal fossa is also damaged because of the cyst that is present. This much amount of information we can gain on a CBCT scan for a cyst as well as a tumor. Moving ahead to maxillary sinus pathologies. This was one of the case of a maxillary sinusitis patient, a chronic sinusitis patient, which was reported for CBCT scan. What you can appreciate here is the axial section. This is the coronal section and this is the axial section that you are able to see. When I'm going to cut the sinus like this and if I'm going to see it, visualize it, this is the radiograph that I'm going to get. What I can see here is the various walls of the maxillary sinus. So the walls of the maxillary sinus, the anterior wall, the lateral wall, the medial wall, the posterior wall, all the walls of the maxillary sinus are visualized in this. What you can see here is a sinus polyp, a dome-shaped radio opacity that is present within the sinus, which is called as a sinus polyp. Good enough? So identification of such type of pathologies is easily possible only with the help of a CBCT scans. Coming to temporomandibular joint, yes, this is quite familiar to you guys. The temporomandibular joint, the internal acoustic meatus, the glenoid fossa, articular eminence, the head of the condyle. So you can watch this head of the condyle with multiple angles. So right from the medial wall, the lateral wall, the superior wall, all those walls in all the multiple angles, you are able to watch it. So whether the patient is suffering from any temporomandibular joint disorders like osteoarthritis or rheumatoid arthritis, or there is wearing of the articular eminence, everything is going to be easily visualized with the CBCT scans. Coming to endo, the use in endo, now one of the endodontists had referred this case to me for the consultation. When the patient was subjected for CBCT scan, what you can see here is highly important plane, that is the axial plane. Now when I'm going to see this axial plane at this level, this is the resultant image that I've got. Understand this, that you are able to see all the roots here. This is the root of 2,4, 2,5, roots of 2,6, roots of 2,7 and 2,8. Easy enough, right? Now what you can appreciate here is the root canals that are present. So 2-4 has got a single root but two canals, the buccal and the palatal. 2-5 also has got a single root and two canals, the buccal and palatal. 2-6 has got three roots which we already know, the mesiobuccal, distobuccal and palatal. But here what you can appreciate is one root canal and there is one more root canal which is present palatally. That is the MB2 that we generally talk about. So this patient has got an MB1 canal, MB2 canal, the distal and the palatal. The pathology that is present is in 7. Is whenever you see this type of pathology, that means there is a developmental anomaly where the roots have got fused together with three different canals in a single root. So what you can appreciate here is the mesial root which is extended till the palatal root and it has got fused together, a C-shaped type canal. But these are actually different three canals which you can easily point out. This type of pathology or this type of, we are able to visualize it is only because we are able to see multiple slices of a tooth. Are you able to understand this? Yes? Moving ahead to prosto, yes, for the prosto CBCT is highly recommended for the patients who are going ahead with implant surgeries. We have already seen this, that we can exactly mention or we can exactly give the length as well as the width of each of the area in the edentulous arches. Now what you can see here, one more thing is that we can go ahead with planning, a virtual planning of an implant. So you can virtually actually place an implant in that edentulous area. So what I have done here is that I have done a marking for mandibular canal and whatever bone width and height was available in this region, I have placed an implant in that region. Now I can see my implant that I have placed in all the multiple angles, that whether my implant is present within the confinements of the buccal and the lingual cortical plates, whether my implant is present, whether it is angulated buccally or it is angulated lingually, all those things are going to be visualized only with the help of a CBCT scans. Now planning of an implant, virtual planning of an implant along with surgical guide. So the entire surgical guide can be planned and that can be 3D printed, which can be directly used on the patient. So there will be no extra surgical part that is required. So what you can do here is the sleeves that are already planned for the placement of implant with angulations. So whatever angulations you wanted to give to the implant, you can do that prior on a virtual planning. You can transfer that into a 3D printing of the surgical guide and you can directly start drilling the bone and placing of an implant through the sleeves. So that becomes easy for a surgical part. Not only planning, but you can go ahead with planning of the crown or the prosthesis that can also take place with the help of a CBCT scans. For perio, what type of bone loss that is present, what type of bone loss is available, whether it is a 1-wall defect, a 2-wall defect, a 3-wall defect, where all there is bone available, how much amount of bone is available, everything can be seen very clearly with multiple angles and the periimplantitis cases in case of perio. For oral surgery, yes, many of the scans have been referred from oral surgery department to be consulted with. So what happens is that an impacted tooth, whenever they are going to be in a questionable or a doubtful prognosis of an impacted tooth, whether it is in close proximity to the inferior alveolar canal, better is to go ahead with the CBCT scan. What you can appreciate in this scan here is a mandibular canal has been marked for this impacted tooth. What you can appreciate in an axial slice is that the mesial root, you can appreciate it here, but the distal root which has got two canals at the apex, and here is the presence of the mandibular canal. So mandibular canal is in very close proximity to the distal root. So if an oral surgeon is going to plan for an extraction, he does not have to go ahead with drilling or applying an elevator pressure on the distal aspect, because you have the nerve which is very close. Now this prior information going ahead with surgery can be possible is only because of the CBCT scans. In cases of trauma, whether it is a simple fracture, a compound fracture or a complex fracture, whether the vital structures are involved or not involved, all those things are possible to be visualized by a CBCT scan. One of the classical case which I wanted to tell you is that a patient reported with a trauma. We had taken a radiograph of that patient, but the patient was continuously complaining of pain. On a radiograph, IOP radiograph, what we got is that a normal tooth which did not had any evidence of fracture. When a CBCT scan was done and every 1 mm slice was seen, what we came across is a dento-alveolar fracture line that was present in this patient. So this was revealed only because the patient was subjected for a CBCT scanning. Now one more case that was referred to us was from the oral surgery department, where the patient had undergone extraction of 8. The patient had healed socket, but the patient still complained of pain. So patient was subjected for a CBCT scan which revealed an fracture line that is present on the distal root of 7. So this type of trauma is basically might be during extraction when the elevators were placed. So such type of injuries or iatrogenic areas or iatrogenic injuries can be visualized on a scan. For pedo, definitely they can go ahead with measurement of the volume of the pulp, the angulation of the pulp with the pulp chamber, with the canals, all those things, planning and evaluation can be done with the CBCT scanning. For ortho people, it is highly important for airway analysis. So the analysis of airway is also possible with the help of a scan. Along with airway analysis, you can also go ahead with entire cephalometric analysis. So what you do, you ask the patient to wait, you take a scan of the patient, the entire computer planning of all the anatomical structures is being done. You just mention which scan or which analysis you want, and that entire analysis along with all the calculations, you're going to get it directly with the CBCT softwares. So to conclude, I would like to still say a fool with a tool is still a fool if he doesn't know how to utilize this tool. I will still suggest that whenever you get a simple case, a normal IOPA, that is intraoral periapical radiograph, is sufficient for give you the regular diagnosis related to that. But yes, whenever you are going to get a complicated cases, it is always recommended to go ahead with the higher scans so that you can get the entire picture that is present. With that, I would like to conclude. Thank you so much.